We're really delighted to be here this afternoon. My name is Dr. Paul Kavanagh. I'm a specialist in public health medicine. I work at the National Health Intelligence Unit, and I'm here with my colleague, Ian Darbey. And I suppose we're going to provide you with an outside looking in view on HYPE because we use HYPE, and we're going to talk about a particular program of work that we lead out on called the HSE Integrated Service Model, which makes, we think, very innovative and very high value use of HYPE data. So it's providing you with sort of an outside view in on all the work that you do. Um, I'm going to start off by giving you a little bit of information in terms of the background to this program of work. There's a particular background story rooted in COVID, which I'll tell you about, and I'll link that as well with some observations around kind of health information within our health system generally. And then I'm going to hand over to my colleague Ian, who will step you through the integrated service model and talk about how it works and how we use HIVE within that. And then I'll come back and I'll offer you some reflections at the very end. So it's over 20 years ago since we published our first health information strategy in Ireland. And since then, we have seen some, oops, yeah, we, okay, jumping along, yeah. We have seen some incremental, but probably variable and sort of piecemeal progress in terms of improving our health information ecosystem in Ireland. So we've seen the establishment of the Health Information Quality Authority. We've seen the advent of air codes, and we're laterally now starting to see those seed within our health information systems. We have seen the advent of the individual health identifier, but again, we've become quite late in terms of seeding that into our health information systems and kind of capitalizing on the opportunities that come with that. And then still we have some gaps. So for example, the identification of population groups in terms of looking at inequalities in health across our population and inequalities in healthcare utilisation. That's poorly visible because we don't have those characteristics routinely and in a consistent way coded on our health information systems. We've established a number of programs in terms of electronic health records, but I think we're some way in terms of harvesting the true benefit that there is from e-health in Ireland. And from a governance perspective, we have had some false starts in terms of the health information and patient safety bill, and then we've had the GDPR, and we've had health research regulations, which for those of us that use health information have probably created some uncertainty in terms of the environment that we work in. And I suppose what all of this means, and it links a little bit with what we heard our CEO say as well, from an individual patient perspective, individual patients come with full rich set of integrated health information to our services. And then we don't always collect all of that information. And when we do collect it, we collect it in sort of piecemeal and disaggregated systems. So all of that information becomes dispersed across our health system and not really valuable then and useful in terms of individual patient care and then strategically planning and managing our health system. And I suppose all of this then came together when we faced into the big crisis, which was COVID back in 2020. And I think one thing that we learned through all of that was that information was power. As I often say, I think if the bars were open in Ireland, they would have been full of armchair epidemiologists. Everybody had a view in terms of data and what was happening in their local area. So we all became really interested in health information, and we all saw that it was very, very valuable in terms of stepping up to that huge health challenge that we were facing. And, it was very useful in terms of underpinning things like contact tracing, very useful in terms of vaccine rollout, very useful in terms of planning how we would scale up our health services in terms of responding to waves of demand that we were expecting, particularly in terms of critical care. So real value around health information. But I think it shone a light on some of those historic issues that I spoke to in terms of the fragility and the weaknesses within our health information system. Because while we had some health information that was useful, and I will call out like HYPE definitely kind of jewel in our crown in terms of quality of health information. We had some health information that was useful in the rear view mirror, telling us what had happened behind us. We didn't really we weren't very good at accessing and mobilizing that in terms of providing us with rich insights, particularly predictive insights into what was coming towards us, which was exactly what we needed in terms of facing into these waves of COVID. So we responded to that within the Health Information Unit by establishing the HSE Integrated Service Model Programme. Briefly, this is about providing a robust, data-driven, expert-informed view of potential demand for health services. Through the model, then it allows us to delineate challenges that are coming towards the health system. So we use a discrete event simulation for that, and Ian is going to speak about that in a little more detail. And critically, then we're able to look at what the impact may be of different scenarios in terms of demand coming towards the health services, but also the impact potentially of different interventions to mitigate deterioration in health service performance in response to waves of demand. So I'm going to hand over to my colleague Ian now, who will speak about the detail just in a little more.
Hi. So one of the first things we start off with is kind of just an example of patient pathways that are built up in the ISM. So each patient arriving into the National Health Service is in their own individual way, has their own requirements. So these are kind of the examples that were worked up to kind of visualize the the care that any given patient would need. And as you can see, one of the key inputs that we have on both patients is HYPE, and that gives us a view of, first of all, how the patient came in to the acute service, either an admission or a readmission, an electively or an urgent care case, and also their discharge destination afterwards. Then, so are they going home? Are they going to the community? And what that means for the. So really, HYPE has been a key data source for building up that initial view of the patient pathway. So if you zoom out, like we're not supposed to do, and then you talk about a system level view of the world. On the left hand side, you have different demand profiles. So the middle one there is actually a piece of work we did on whether there would be uh, a bounce back of elective care demand on post COVID, which we're beginning to see now. And then you have potential COVID surges, or trying to understand when COVID was in abatement and easing off. On the right hand side, we have the KPIs that we output, which are, as people will probably guess, trolley and occupancy related. But at the center of it all, then is that piece in the middle, which is this piece. Oh, this piece here, I can't use the pointer evidently. There's the fight between elective and emergency care at each hospital site uh, for the same number of beds. They don't change it because there's 20 elective admissions due on a given day. That doesn't affect the number of patients that arrive to the ED. So it's that battle between acute, unscheduled, and elective care that is really at the forefront of what the model can do. So what we really try and do is hold up a mirror to the service, not just at a national level, but also at a site level. And to do that, we have to look at things through different lenses. And for us, HYPE provides an awful lot of those different lenses that we look at things through. So the first thing we look at is the overall acute demand for inpatient hospital care. So we've done historic demand for daily admissions from 2005 right up to date, and then done that on a per capita basis for the population to try and understand the trends that are emerging across age groups. We split them into three different age groups: 15 to 64, 65 to 79, and 80 plus. And then we have built up a projection of what the future demand will be across those age groups. And more recently, we've integrated population projections from the CSO and Ukrainian refugee arrivals post the war in Ukraine. That gives us our estimate of future demand. And what we've seen across that data is an actual underlying trend where per capita demand is going down. So we're doing better, we're serving communities better. But the problem is the population is growing, and it's growing in the older age groups where demand is more likely to occur. Uh, Once you get beyond that national level, then you are into the split between sites. Um, so it's really important for us to understand where the demand is going in terms of what sites are potentially to be very busy versus other ones that might see less demand. And this allows us to spot trends and different things that emerge. So one of the things that emerged in the immediate aftermath of COVID was that we saw a significant surge in proportion of demand that was heading towards Model 4 hospitals versus the other hospitals. And what you do then is you essentially create a choke point where all the demand is heading towards these areas. Now, these were relatively minor shifts. I know they look big in the graph. This is a couple of percentage points really in a shift, but that is enough to cause serious problems in an acute system that is already under significant pressure. Beyond that, then, we then have the split between unscheduled and elective care. So we have a view in the longer term. Inpatient care oftentimes has been provided, or historic inpatient care has been provided as day cases now. But in addition to that, we have essentially what we've got is elective care being squeezed out of the constrained capacity in the acute system. So we can visualize that, and we can understand that, and we can project that forward. And then once we get it into an individual site, we can, and this is just, I suppose that graph is just to visualize the variability within the data. That is a specific hospital site, and that is the proportion of patients that are going through each specialty within that site. And it's just the spaghetti mess, is, I suppose, to highlight how variable that is on a given time. And part of what we do is really trying to represent that variability. The other bit that is highly variable, obviously, within healthcare service delivery is length of stay. So for each patient that comes into the simulation, we randomly sample it. The variability is based on fitted type actuals. So for the specialty, the age group, the hospital, and the admission type, we fit a distribution for that particular length of stay. We do have future development plans to go down to procedure level that will be a bit more granular, but each patient length of stay is then sampled so that we can collectively across all the patients in a given hospital and all the patients nationally then understand what is the demand for bed days, which ultimately then translates into trolleys. I touched on this earlier on, but it's the admissions and discharge patterns. I suppose one of the things that HIPES gives us is an idea of when someone has finished their acute care episode, where are they going to next? So are they going home, potentially home with supports, short stay, rehab type facility, or are they going to the long-term residential care? These are the types of things that for us to build in the community element of the ISM, we need to be able to understand what those pathways are out of the acute setting, which HYPE gives us better than any other data set. So these are just some examples of some use cases we've completed recently and different analysis. So we modeled the potential impact of the proposed initiatives for winter plan that is just finished. We've modeled capacity expansion. So we built up a model of system performance from January of this year to April of next year, with the idea being that it would support decision making around significant capacity investment, which I think most people would be aware of. And then at the moment, there's a massive body of work involved in the unscheduled and emergency care framework. So as part of that, we've built up a future demand that is going all the way out to 2027 to understand the demand across acute and community services. And then in addition, and I know Brian and colleagues in the HBO do an awful lot of work in this area, we've also done an analysis of length of stay, both nationally and at site level, to understand the variance. And we've some interesting findings that we've presented back to the operations colleagues, particularly around the level of acuity of the setting as opposed to the patient having an influence on the length of stay. And it's just to say, again, it's probably obvious, but all of these kind of analysis, all of this is based on HYPE being a key central data source for us. So when people talk about HYPE, often they focus on the funding element, and the finance is obviously an important part of it, but being able to have a clear source of truth for what is the activity going through an acute hospital. And then beyond that, when you go beyond an individual site and you go to national level, being able to understand the demand on a national level and where it's going is very, very important and a key part of what we do.
Great, Ian. So just to wrap up then, in a couple of minutes with some kind of helicopter reflections, kind of from our experience of doing that work. So again, CEO, I think, stole my thunder on this point, and it's that I think when we think about the work that we do in the health services and we think about saving lives and improving health, people will think about the NAS service, ambulances, they'll think about operating theatres, they'll think about vaccine rollout, etc., etc. But I suppose I would really like to think that when people look back on the conference here in Galway and the work that we do together, people will recognise that the work that we do in terms of building health intelligence, and as I said, hype is really the crown jewel of that, and then the work that we do with you to get greater use of that health intelligence is ultimately about saving lives and improving health. But I think if we want to work towards that vision, as I set out at the start of the slide, I think we have a bit of maturity to do in terms of our health information system and how all that gets linked in terms of decision making. This is well recognised. People will be familiar with a number of the key publications from the Health Information and Quality Authority, which have really underscored the need for improvement in terms of our health information system. Europe are on this as well. So we heard about this from Brian in terms of the presentation around the Health Information Bill. So Europe are interested in this space, the European health data space. Obviously, that'll have benefits from citizens, but there's quite a kind of private or commercial interest around all of that as well, because everybody recognises that health information is commercially hugely valuable. And I suppose it falls to us in terms of running our health services to match that and to see ourselves how valuable the asset is that we build in terms of health information, and hype being the key example of all of that. And I suppose the great news, as Brian said already this morning, in terms of the presentation from our colleague Peter, great work ahead then in terms of building the platform that will lead to improvements in health information in Ireland through the forthcoming health information bill, and we're very much looking forward to that. In terms of where things go next, I think within health a huge opportunity for us to look at building on the opportunities that there is around big data, so around bringing together our various different health information systems and then applying the technology that we know is now actually kind of the mainstay in other sectors, like for example financial services, to provide better insights in terms of what the future holds and how we plan and move towards that in terms of health. The DASA model, which people may be familiar with, is an attempt to try and build that infrastructure from an external researcher perspective. And I think then within the health services, there's a real value opportunity for us to look at how we respond to this sort of agenda in terms of trying to bring together the various different silos of information into an integrated system and put the technical infrastructure and importantly the culture around that as well, which makes sure that that's useful at an individual patient care level and then also at a overall system level. So just in terms of wrapping up and our own experience of working on this program over the last couple of years, I started probably with a very kind of bleak picture in terms of the state of the health information system, spoke about how we responded to the COVID challenge in terms of mobilising the integrated service model program and the great partnership that we had with Brian and colleagues in HYPE, which is a very key element, a central element to all of that, as Ian set out to you. So in terms of looking forward to the future, I would say, I like this quote from Seamus Heaney where he distinguishes between optimism and hope. And I would say I'm not just optimistic, but I think I'm hopeful based on recent experience that has built our conviction that evidence at the centre of health system decision making is something that is really seen as useful and something that we all want to work together towards building. So I look forward to continue to work with colleagues in HYPE and very much want to acknowledge and thank them in terms of their collaboration underpinning the work that we presented to you today. So thanks.